Today I'm going to talk about phototherapy in pediatric psoriasis. These are my conflict of interest, but none of them are relevant for the talk of today. You know, when we start thinking on phototherapy, it's incredible how brilliant this therapeutic option is, and it's over 3,000 years have been used in different scenarios. You know, in Egypt and in India, it was first started using for leukoderma. And then in the Nobel Prize winner, Niels Finsen, started to use phototherapy for curing tuberculosis. So we have a lot of experience in phototherapy in multiple conditions, and I think that it's crucial for us as dermatologists to understand and use phototherapy better. The definition of phototherapy is a medical treatment that uses controlled exposure to a specific wavelength of ultraviolet light to manage and treat various conditions. And as you can see in the diagram, we have a different spectrum of UV light. We have UVC, UVB, and UVA, and we will see it in more detail right now. So we have first UVC, which is not important in this scenario because the penetration of UVC is really low, but it helps in other conditions. And basically, in dermatology, we tend to use UVB and UVA. UVB has a low penetrance, so it can target basically keratinocytes and Langerhans cells, and UVA is capable of going really deeper, affecting the dermal lymphocytes, the fibroblasts, etc. Phototherapy promotes 6 key effects. Of course, immunomodulation, which is like the main effect here for psoriasis, but also induces apoptosis, skin pigmentation, antipruritic effect, which is really important in patients with psoriasis, especially in children, antifibrotic effects, and pre- and probiotic effects. And especially in psoriasis, the mechanisms of actions are as followed. First, the inhibition of antigen presentation by the dendritic cells. Second, the inhibition of the T cells, and this provokes an apoptosis induction in basophils, B cells, eosinophils, and mast cells. And finally, the inhibition of synthesis and release of pro-inflammatory mediators. There is a wide spectrum of dermatosis that can be treated with UV light. Please check this slide. I think, again, as dermatologists, we are the main specialists using this kind of treatment option. So please take a look at this, check it in detail, and use it in your daily practice. As any other treatment option, phototherapy also has contraindications, and mainly are the history of photosensitivity disorders or the use of photosensitizing drugs. For sure, there are some other contraindications, including the personal history of non-melanoma or melanoma skin cancer. And I would like to point to you the photosensitizing drugs. Several drugs can increase the sensitivity to the UV. So it is important to educate our patients to tell us in every single session if they are using one of those drugs, especially the ones that are highlighted in red, in order to decrease the amount of energy during this session and avoid the side effects. Let's go in detail from UVA and UVB. UVA light is widely used due to its ability to penetrate deeper in the skin. And we have UVA1, which penetrates even deeper, so it's used in morphia and conditions related to this skin disorder. And we have UVA2, which is not really used clinically. UVA has systemic effects acting on circulating immune cells, and it requires psoralen, except when we are using UVA1, and for sure it's useful in psoriasis, but also in other conditions such as atopic dermatitis, graft versus host disease, and PPP. How to start the treatment with PUVA? This is the American protocol for dosing PUVA according to the patient's skin phototype. So please notice, with the skin phototype, we determine the initial dose, the increments, and the maximum dosage in order to avoid the side effects. In other matters, we have the UVB, and this is the most common used form of phototherapy. The dosage of UVB can be determined by the skin phototype, but also we can use the MED, or the minimal erythema dose, which is the smallest dose of radiation that causes a minimal erythema 24 hours after irradiation. And in UVB phototherapy, we have the narrowband UVB, which is less erythemogenic with the same energy applied. In this slide, we can see the protocol of narrowband UVB according to the skin phototype. Remember, you can also measure the minimal erythema dose if you want to do it. And we usually start with 70% of the minimal erythema dosage. Please also notice the maximum dosage of the treatment. And so sorry, I just realized it is in Spanish. I'm sorry, I forgot to translate it. There are different ways to deliver UVB, and we have these high-intensity localized systems, the excimer laser and the excimer light. And here you can see a comparison table of both technologies, the laser and the light. I have to say that the price is the main difference between both options. However, in terms of safety and efficacy, they are mainly the same. So we started talking about phototherapy. Let's take a closer look to the pediatric population and psoriasis. We're going to start with the Italian consensus on the treatment algorithm for psoriasis in patients under 18 years old. And phototherapy here is considered a first-line option for moderate to severe disease in patients over 12 years old. Phototherapy is an effective treatment for moderate to severe plaque psoriasis, but also guttate psoriasis, which is quite important in this age, in this population. Something we have always concerned about is the risk of skin cancer. And our Italian colleagues appointed that there is no increased risk of cancer using narrowband UVB. Studies showed up to 50% of skin clearance in children with psoriasis in patients between 5 and 17 years of age. And there's something I think important, that we can pre-treat the patients with emollient because it enhances the narrowband UVB effectiveness, reduce the lesion severity, and also the UV dosage needed for clearance. They also talk about the narrowband UVB at home. However, we don't have a lot of clinical data, but I think it could be an option. This is another article specifically regarding childhood guttate psoriasis. And here, narrowband UVB appears to be the first-line treatment option for patients over 6 years of age. Narrowband UVB is recommended over PUVA, and it's safer than PUVA in the short term, but also in the long term. And the combination of UVB narrowband and topical treatment, again, can increase the efficacy and reduce the dosage of UV light. So I think it's important, the combination in all of our patients. But what about the real-world evidence? And right now, I'm going to present you 2 studies. The first one is from the UK. 100 children were included, and you know that most of them, 74 of them, had psoriasis. It was about phototherapy in general, so 74 patients had psoriasis. And regarding safety, mild to moderate erythema occurred in half of the patients, but severe reactions were really infrequent. So most of them were really mild and didn't stop the indication. Let's focus on our topic in psoriasis. The sample size for this real-world evidence data was 74 children, most of them women, most of them with UVB narrow band. The normal cycle, including 20 sessions, and I think it's most of our cycles are around this amount of sessions, 3 per week in narrow band, and 85% of the patients showed a graded improvement of psoriasis, whether only 6% worsened. I think that here is something remarkable about phototherapy. 72% of the children had no relapse after 2 years of the therapy. So it's not only a treatment for a short term, but also for long term. And PUVA and broadband UVB showed great improvement, but the sample size were really low, so we don't have anything to show more in detail. And for today, this is the last study for real-world evidence from the US. It is a survey by 39 sites, and almost every site performed pediatric phototherapy. The minimum age of treatment has a huge variation, and Fitzpatrick skin phototype was the parameter to calculate the dosage in all the sites. There were some special accommodations, and I think it's important if we have to treat patients, especially children. For instance, they had a space for the parents and space for children with disabilities. They showed some barriers. I'm pretty sure it's worldwide, including the coverage, the scheduling, and the distance. And most of the sites performed narrowband UVB or PUVA. Some studies have suggested that in children, the use of height may be more appropriate to measure the UVB irradiance because of the different proportions on children. However, actually all of the sites didn't use the height, they really used the skin phototype. Most of the sites in the US treated patients regardless of the age. And in this particular article, they ask for future guidelines, standardizing the practice because a real strong consensus on pediatric phototherapy has not been published. These are some tips for the phototherapy units for children. You know, it's important to have some special conditions, such as maybe playing music during the treatment, split the dosage when the patients are too long during the cabin, and explain the patients and the parents the safety requirements, and maybe the schedule early in the morning or in the afternoon in order to get more adherence. Here are some important facts about the therapy. One cycle will have around 20 to 24 sessions, 2 or 3 times in a week. And the time in the machine is shortened in UVB narrowband protocols, which is around 30 seconds to 4 minutes, and it's longer in UVA, where it's around 30 minutes. The minimum time for response could go from 15 to 20 sessions, and this is important because sometimes patients are in like the 8th or 10th session and they are asking for results. They have to be patient. The maximum number of sessions in UVA using PUVA, it's around 200, and UVB, it's really unknown. We can use concomitant treatment with phototherapy in childhood, as we are doing in adult patients as well. Mostly in children and adolescents, we will use topicals. But if we need it, we can use all these other options. Remember, we can use PUVA topically, because sometimes we have the awareness of the liver function, etc., but we can use a topical Sorolin, 0.1%. The side effects are kind of the same that in the adult population, are not so common, are well known, and most of them can be prevented. I think that in children, we must add the anxiety about the confinement only if we are using cabin phototherapy. But we know that we don't have to use it cabin for all the patients. Sometimes we can use the lamp or even the excimer, and this is easier for the patients. In terms of efficacy, phototherapy is really remarkable, showing similar results than so much more expensive drugs as biologics, having affordable costs, which is truly important for today's economy. And please take a look at that. After 24 sessions of phototherapy, the efficacy is around 75%. Really good. In this meta-analysis, the global efficacy of narrowband UVB for children with psoriasis was around 80%. So it's a very, very good option. And finally, my final comments, I think that phototherapy is cost-effective, and not only for psoriasis, for a wide range of dermatosis. There are few treatments in our field that have the history, the efficacy, and the safety of phototherapy. So we are, as dermatologists, we are the only group of physicians who are trained and qualified to recognize when to use it and to use it. So let's use it more often. And I hope that I push you a little harder for the use of phototherapy, and I hope to enlighten some of your patients too. Thank you so much.